This explainer is engineered for one very specific purpose: hardwiring your brain for relentless pattern recognition for USMLE Step 2, CK, hematology, and oncology. We are completely bypassing the educational fluff to build the diagnostic reflexes you absolutely need for the wards and, more importantly, the wards.
Our agenda for this session: post-transfusion reactions, leukemia footprints, lymphomas and oncologic emergencies, and finally, cognitive memory traps.
Module 1, Post-Transfusion Reaction Mechanisms and Immunological Separation.
All right, let's break this down. Acute hemolytic reactions, they're going to hit fast. We're talking under 1 hour. The mechanism here is ABO incompatibility, which is a type 2 hypersensitivity causing massive intravascular hemolysis. Your key signs are fever, flank pain, hemoglobinuria, DIC, and shock. The immediate move, you stop that transfusion right away. Now, contrast that with febrile non-hemolytic reactions. The onset is a bit slower, typically 1 to 6 hours. This one is simply caused by cytokine accumulation in stored leukocytes, and the treatment is straightforward: acetaminophen. And what about anaphylactic reactions? Well, they happen in minutes. You'll classically see this in IgA-deficient recipients who are receiving IgA-containing blood products. The key treatment? Immediate epinephrine. Don't wait.
Now, you've got a critical 6-hour window, and the differentiator usually comes down to TRALI versus TACO. TRALI, or transfusion-related acute lung injury, is non-cardiogenic pulmonary edema. What's happening is donor anti-HLA antibodies are aggressively attacking the recipient's neutrophils. This causes bilateral infiltrates and fever, but importantly, and this is key, a totally normal JVP and BNP. TACO, on the other hand, is hydrostatic volume overload. This presents with hypertension, JVD, and elevated BNP, and it responds beautifully to loop diuretics.
Okay, let's test this reflex right now with an advanced board-style clinical stem. An elderly male develops dyspnea, JVD, and bilateral crackles within hours of receiving 4 units of packed red blood cells. His blood pressure is 170/95. What is the exact diagnosis and mechanism? Take a second and lock in your answer. So how do we break this down? The crucial point is choice-by-choice elimination. ABO incompatibility is out. That would present with shock and flank pain, definitely not isolated hypervolemia. Anaphylaxis? That features immediate bronchospasm and hypotension, not a BP of 170/95. TRALI presents with hypoxia and infiltrates, sure, but the JVP and blood pressure would be perfectly normal because, remember, it's non-cardiogenic. That leaves us with TACO. The hypertension, the JVD, and the elevated BNP pathognomonically isolate TACO. It's hydrostatic volume overload, requiring temporary respiratory support and loop diuretics.
Module 2, Acute and Chronic Leukemias, Pathognomonic Footprints.
Let's catalog the big 4 right now. ALL is the most common childhood malignancy. They'll present with bone pain, bone marrow failure, lymphadenopathy, hepatosplenomegaly, and TDT-positive lymphoblasts on a marrow biopsy. An easy way to remember? Think of TDT as the toddler marker. AML? That hits adults. Look for myeloblast containing our rods on the smear. Then you have CML, which is defined by the T922 Philadelphia chromosome, creating that BCR-ABL fusion tyrosine kinase. It presents with profound leukocytosis, a left shift, and it responds brilliantly to imatinib. Finally, CLL is an indolent lymphocytosis in older patients. It's marked by characteristic smudge cells on the peripheral smear, and it carries severe risks like warm autoimmune hemolytic anemia and a Richter transformation into DLBCL.
Time for a high-stakes clinical stem. A 60-year-old male presents with acute bleeding gums, petechia, and a white blood cell count of 80,000 composed of 80% blasts with our rods. Cytogenetics show a T15-17 translocation. What is your diagnosis? And honestly, more importantly, what is the immediate threat? If you said acute promyelocytic leukemia, or APML, you nailed it. And this brilliantly illustrates a critical board concept. The T15-17 translocation carries an immediate, life-threatening risk of disseminated intravascular coagulation, or DIC. You don't just diagnose this and move on. You must urgently intervene with ATRA, that's all-trans retinoic acid, and you correct the coagulopathy emergently. Module 3, Lymphomas, Plasma Cell Dyscrasias, and Oncologic Emergencies.
Notice the bulky bilateral hilar lymphadenopathy here, contrasted directly with the classic binucleate Reed-Sternberg cell. You know, the famous owl's eyes? This is Hodgkin lymphoma, which is characterized by contiguous nodal spread, systemic B symptoms, and CD15 and CD30 positivity. Contrast that directly with non-Hodgkin lymphoma, which behaves quite differently. featuring unpredictable, non-contiguous spread and a lot of extranodal involvement.
See how these red blood cells are aggregating and stacking up almost exactly like a roll of coins? That is classic rouleau formation. It happens when there's an overproduction of monoclonal immunoglobulin chains in the serum, making things sticky. This is the absolute visual footprint of multiple myeloma, a malignant clonal plasma cell proliferation.
To lock in multiple myeloma, just anchor your brain to the CRAB criteria: hypercalcemia, renal failure, anemia, and lytic bone lesions. These patients are going to present with fatigue, back pain, and a distinct monoclonal M spike on their serum or urine protein electrophoresis. When dealing with oncologic emergencies, strict order of operations is literally a matter of permanent paralysis or walking. For spinal cord compression, step 1, suspect it in any cancer patient with localized back pain and progressive upper or lower motor neuron deficits. Step 2, give immediate high-dose IV dexamethasone. Step 3, then you get the emergency spinal MRI. We also need to keep other oncologic emergencies on our radar here, like SVC syndrome, look for facial plethora, JVD, and collateral upper chest wall vein expansion caused by a mediastinal mass compressing the superior vena cava. And don't forget tumor lysis syndrome, hyperuricemia, hyperkalemia, hyperphosphatemia, and secondary hypocalcemia following chemo.
Let's apply this algorithm directly. A patient with metastatic lung cancer presents with localized back pain and progressive hyperreflexia in the lower extremities. What is the strictly mandated next best step? The absolute mandate here? High-dose intravenous dexamethasone prior to obtaining any imaging. Delaying steroid administration just to wait for an MRI in a patient with progressive motor neuron deficits will lead to irreversible paralysis. Treat first, image second.
Module 4, Accelerated Pattern Recognition and Memory Traps. Trap number 1, delaying the termination of a blood transfusion because you think, oh, it's probably just a mild febrile reaction. No way. Here is the rigorous justification. Any fever post-transfusion must be treated as a potentially fatal acute hemolytic event until you prove otherwise. Stop the transfusion immediately, never ever wait, give vigorous IV fluids, maintain urine output, and investigate. Only after ruling out life-threatening mechanisms can you safely label it a benign febrile non-hemolytic reaction. Trap number 2, giving loop diuretics to a hypoxic TRALI patient. TRALI is non-cardiogenic pulmonary edema driven by a severe immune attack on recipient neutrophils. It is not hydrostatic volume overload. If you give loop diuretics to a TRALI patient, you will fatally crash their hemodynamics. Diuretics are strictly reserved for TACO. Moving on to Trap 3, confusing normal bone aging with multiple myeloma lytic lesions. Normal bone aging, like osteopenia, is diffuse. Multiple myeloma presents with discrete, punched-out, lytic bone lesions, often right alongside unexplained renal failure and hypercalcemia. Do not let generalized bone pain in an older patient blind you to the CRA-B criteria. And trap number 4, delaying time-sensitive rasburicase therapy during a severe tumor lysis cascade. When you give chemotherapy for bulky tumors like leukemia or lymphoma, massive cell breakdown releases a ton of intracellular ions and nucleic acids. Uric acid crystals will rapidly destroy the kidneys. Aggressive IV hydration and uric acid clearance using rasburicase or allopurinol are required immediately following chemotherapy to prevent acute renal failure and lethal hyperkalemia. So this brings us to a final, pretty provocative thought. If a Step 2 CK question presents a sudden onset oncologic or hematologic crisis, are you just reacting to the symptoms, or are you actively anticipating the underlying cellular pathway? The absolute key to mastering this material is seeing those pathognomonic footprints before you even reach the answer choices. Lock in these mechanisms, sidestep those cognitive traps, and you will absolutely own this section.